Yes. So most welcome to your Pediatric Advanced Life Support CME. My name is Edgar. I am an administrator here at Quality Care. So for the benefit of those who are possibly joining us for the first time, we'll go ahead and just do a very brief introduction, just to tell you a bit about Quality Care, who we are, what we do, and then after that, we'll get into the PALS CME. So Quality Care is an international training center that is based in Nairobi, a place called Fifth Avenue Suites. So as Quality Care, we train, essentially we train life support courses. So by far the most popular course we have is basic life support, advanced cardiac life support. We also train clinical ECG, interpretation training. We train pre-hospital trauma life support training. We train point of care ultrasound training. We'll actually be having a podcast training next week. And last but not least, we train pediatric advanced life support. So personally, I would say in most cases, it is rare for PEDS population to actually enter cardiac arrest. But when it does happen, the knowledge that you get in the pediatric advanced life support training will be the difference between saving or not saving your patient's life. So we hope after today's CME, you'll actually consider doing pediatric advanced life support as a whole, so that you can have a proper body of knowledge that when your patient goes into cardiac arrest or during an emergency, you're actually well equipped. You can confidently act and actually save your patient's life. So basic life support for the foundation for everything else, even in pediatric advanced life support, basic life support is important. So in that regard, we're actually doing something called the Life is Why campaign. So as part of the Life is Why campaign, we are going to county hospitals. We are training people on how to do high quality CPR. A grim statistic to keep in mind is that cardiac arrest is actually the #1 killer of both men and women in the whole world. So I'll repeat, cardiac arrest is actually the #1 killer of both men and women in the world, more than all forms of cancer combined. So as in your career as a medic, at some point you will come across a patient who goes into cardiac arrest. And when that happens, high quality CPR will be the difference between saving or not saving a patient's life. So as part of Life is Why, we are doing inter-county trainings. We'll actually be in Kisumu in May. So in case you have a friend or a colleague who's interested in finally being certified, they've been thinking about doing basic life support, advanced cardiac life support for quite some time. But for one reason or the other, they just haven't possibly gone and done it. We'll be in Kisumu in May. We'll be in Mombasa in May. We'll be in Tumutumu. We'll be in Nyeri. We'll be in Murang'a. And we'll be in Machakos. So in case you yourself, you're actually in these counties, we would encourage you, please get in touch and train. It's super important to train. So basic life support, advanced cardiac life support being the core of Life is Why. Possibly you work in a certain hospital, maybe high quality CPR is not practiced. Please invite us. We will come and do a CME on high quality CPR. So here you can see soldiers. 17, 18, doing high quality CPR. So apart from medics, everybody should learn how to do high quality CPR because most cardiac arrests actually happen outside of hospitals. So if you do have the knowledge and the skills, when the time comes, you're able to save a patient's life, which is the goal of these trainings. So here we can see basic life support training for non-medical staff. This is a sports club. This is a HR officer. These are gym instructors. So they had a child, a pediatric population, swim. The pediatric population was swimming, and then, this pediatric population almost drowned. So they didn't actually drown, they almost drowned. They got the patient outside of the pool, but no one actually knew how to resuscitate. So that's why we actually went and trained. So basic life support, super, super important. Here we have pre-hospital trauma life support training. I would say, in case you deal with trauma patients a lot, pre-hospital trauma life support is very, very important. Most of the damage done to patients who get into car accidents, essentially trauma patients, most of the damage done is during moving this patient from scene of accident to hospital. So pre-hospital trauma life support equips you with the necessary skills to actually move your patient in a safe way, which doesn't cause damage. So having said that, we welcome you a lot to the Pediatric Advanced Life Support CME. We also have a number of other courses that we offer. For those who have just joined, basic life support, advanced cardiac life support, pediatric advanced life support, pre-hospital trauma life support, and point of care ultrasound training. Yes. So specifically for pediatric advanced life support, we hope that you will join us in the coming one. We just had one which just ended. From the poll, from the registration that we got, majority said they are very, very interested in doing pediatric advanced life support. So we hope you will join us. So most welcome to our CME today. My name is Edgar. This is our location. We are at Fifth Avenue Suites at 8th floor at Quality Care. In case you have any questions, perhaps you want to visit us, talk about possibility of training, we welcome you a lot. This is our website. This is our Facebook page. You can also have a look. In case you like what you see, we request that you please leave a like there. So thank you so much. I think I'll now hand it over to the instructor for today. Instructor for today is Eric. Eric Menya is a senior AHJ instructor, basic life support instructor, advanced cardiac life support instructor, pediatric advanced life support instructor, and also a trauma life support instructor. So now I'd like to hand over the floor to Eric so that we can go ahead and get into the business of today. So thank you very much, Eric. Please go ahead.
Uh, welcome, guys. On the initial thematic approach to pediatric assessment of pediatric emergency. Has shared. My name is Eric Menya, and I'll be your instructor for today. Now, one of the key steps when it comes to patient management is actually assessment. All right. Okay. So, yes, thank you, Edgar. So, one of the key things that I want us to discuss initially is the pediatric chain of survival. So the AHA has something it calls the chain of survival, which highlights the very important steps that you need to undertake in case a patient is in a cardiac arrest or at risk of one. So how do we improve patient outcomes when it comes to cardiac arrests? And the first link in the pediatric chain of survival for in-hospital cardiac arrests, so abbreviated IHCA, is usually early recognition and prevention. So early recognition and prevention refers to the step whereby you monitor your patient, all right? You keep track of their vital signs and you do a thorough assessment of your patient, and you're able to then identify the potential causes of a cardiac arrest early and intervene. So in terms of your H's and T's, be it hypoxia, be it hypovolemia, which are the commonest causes of collapse in pediatric patients, be it hypothermia, be it hypo or hyperkalemia, be it hypoglycemia or hydrogen ions acidosis. You are able to identify that early enough. If it's a tension pneumo or it's a tamponade cardiac, possibly, or it's a toxins issue, early recognition and prevention is the initial step to managing these aspects. So when it comes to the systematic approach, it helps us have a systematic way in which we assess our patients and intervene early. Now, in case that fails, then the next step in the chain of survival for pediatrics in hospital is usually activation of the emergency response team. So activation of the emergency response team, this team must be composed of individuals who understand what they're doing, individuals who are trained in the provision of advanced life support or advanced resuscitation, particularly in pediatric advanced life support. This is usually then followed by high quality CPR, and Edgar has mentioned the campaign that is ongoing just to try and improve our knowledge of high quality CPR and how to provide it. This is then followed by advanced resuscitation or advanced life support provided by this emergency response team that was activated, followed by post-cardiac arrest care, and then recovery. So you find whatever we are about to discuss today forms the initial foundations of patient management and prevention of a cardiac arrest. Now, when it comes to patient assessment, so we are here, early recognition and prevention. So when it comes to patient assessment or the systematic approach to pediatric assessment, the initial step, so our objectives, of course, will be thematic approach to pediatric assessment. We will also discuss the early signs of respiratory and circulatory compromise. We will review in brief, though we won't talk about it at length, we will review, time permitting, some few interventions that you would need to undertake in case of respiratory failure, or in case of shock, or in case of cardiac arrest. So some of them we have already mentioned. So the first thing that we need to understand when it comes to patient assessment and the systematic approach, we are using the evaluate, identify, and intervene sequence. And it's a continuous cycle. So you are evaluating your patient. You want to find out, what am I dealing with? What is likely to cause a cardiac arrest in my patient? And this evaluation is in steps. You do an initial assessment based on the pediatric assessment triangle, which we will discuss. You do a primary assessment for your patient, and you do a secondary assessment once you have dealt with the life threats. Okay, this allows you to identify. Now, when it comes to identification, we have said you could be dealing with a respiratory issue. This is the broad category of issues that can lead to a cardiac arrest, or the pathway to a cardiac arrest for your pediatric patient. You could be dealing with a circulatory issue. So you are trying to identify, what is it? Is it respiratory distress? Is it respiratory failure? Okay, if it's respiratory distress, what is causing it? Is it being caused by an upper airway obstruction? Is it being caused by a lower airway obstruction? Is it being caused by a lung tissue issue or lung tissue disease? Is it being caused by a disordered control of breathing? If I'm in distress, what do I do? If I'm in failure, what do I do? Because the management differs. And how do you distinguish between failure and distress? So I know because of time, we possibly will not be able to cover all these things, but we will cover at least the systematic approach to assessment. Is it an arrhythmia that is causing my patient's issue? And this is not as common. This is common in the adult population, but in the pediatric population, likely it is a respiratory issue or a circulatory issue. Once you identify, if it's a circulatory issue, is it compensated or decompensated shock or hypotensive shock in terms of severity? Manage accordingly. So that is where now your intervention then comes along. So this is actually the structure of the PALS course, the Pediatric Advanced Life Support course, that it goes into detail about all these aspects. So what we have picked today is just to talk about how we evaluate. Okay, so how do we evaluate? So the first thing we do is an initial assessment. So your initial assessment is a rapid visual assessment within 30 seconds. So your patient has just been brought in to your consultation room, or you have gone to the patient's ward or wherever they are, and you are doing a quick assessment using the pediatric assessment triangle. You do a rapid visual assessment, and you are then able, the purpose essentially is for you to be able to determine whether there's a need for immediate urgent intervention, or you can actually progress to doing your primary assessment. So your initial assessment tells you this patient urgently needs the emergency response team to respond. Or this patient, I can proceed and take my time and do an assessment. What are the components of the pediatric assessment triangle? It's A, B, C, essentially. So instead of A being airway, we are assessing the appearance. And that is the most important aspect of the pediatric assessment triangle. We are assessing appearance. Okay? We also assess the work of breathing. So that is our B. And then we assess the circulation. That is our C. And these things are done visually. You are not yet touching this patient. So it's a very rapid, quick assessment to be able to identify life-threatening illness or injury and determine the need for simple interventions such as application of oxygen or oxygen supplementation and the activation of the emergency response team. So what does it entail? At appearance, we check a number of things. We check the degree of interactivity. We check the muscle tone. We check the verbal response or cry of this patient. So we use a mnemonic or I'll say a mnemonic called tickles. So tickles, we are basically saying, check the tone of your patient. If we are talking about an infant, for example, you expect that an infant would be having spontaneous limb movements if they are okay. So if you walk in a room where there's an infant and you're doing your initial assessment, you're observing their tone. How are the limbs? If they are awake, are the limbs moving spontaneously? All right. If it's an older child, how are they? How is their posture? Are they seated upright? Is the neck upright? Are they able to hold up their head? All those things. So you are checking the tone of the patient. Is it appropriate or reduced? The I is for interactivity. Interactivity. So interactivity, you are checking how well the child is interacting with their environment. So if it's a very young child or a small baby, then you want to particularly you want to look at how they are interacting with what is around them. Okay? If there's a sheet, are they grabbing this sheet? How are they interacting with their environment? If they have a pacifier, are they sucking on the pacifier? All right? So interactivity. You want to check the consolability of the baby. If the baby is crying, are they consolable? Because when we look at the pediatric GCS, particularly for infants, one of the things we look at verbal response is whether the child is consolable. So usually, of course, if they are oriented and cooing or babbling, that is good. That's a score of 5. If this child is irritable, they are crying, but their mother or caregiver is able to console them, then that's a score of a 4. If this child is crying inconsolably, that's a score of a 3. So consolability is a very important component in your initial assessment. The next thing we look at is the look or the gaze of this child or infant. How is their look or gaze? Are they looking at something and following it as it moves? So, for instance, if you walk in the room, Do they make eye contact, or do they turn to acknowledge your entry or the commotion? Are they able to follow an object across the room, or is their gaze fixed? Now, a child with a fixed gaze, that is a severely ill patient. That's abnormal. So the look or gaze is very important. The other thing we look at is the speech or cry. The speech or cry. All right. So the speech or cry of the baby. So at appearance, if there is an abnormality at appearance, and it's not that this baby or child is asleep, then you need to activate the emergency response team. Okay? Because that is a severely ill child. The next thing we look at and we listen for is the work of breathing. So A, B, C. So at work of breathing, you check the positioning of the baby or child. Are they in the tripod or sniffing position? Are they trying to compensate to make their breathing a bit easier? Do they have any retractions? Do they have audible breath sounds that you can hear? Okay, so are there abnormal sounds that you can appreciate, such as stridor, wheezing, all right, snoring, gargling sounds? Those are things that tell you a story about the kind of problem you are dealing with. Do they have head bobbing, for example? Do they have, what else can you see? Do they have nasal flaring? These are aspects that you observe for. Now, at circulation, you then check the color of the baby. So, do they have pallor? Do they have mottling? Do they have cyanosis? These are different stages of circulatory compromise. Now, from there, you are able to tell if they have an increased work of breathing and reduced level of consciousness at appearance, then you activate your emergency response team and you immediately start oxygen supplementation. Even if it's before we have checked their SpO2s, you start them on oxygen supplementation. All right. And then, of course, you prioritize pulse oximetry and cardiac monitoring of the patient. Now, from your initial assessment, you will either activate the emergency response team or you will proceed to your primary assessment. So if this baby or child is stable, you have checked your initial assessment, there's no life threat, you proceed to your primary assessment. If this baby is not stable, you first of all activate your emergency response team, initiate interventions such as application of oxygen, and pulse oximetry and possibly cardiac monitoring, and then move to your primary assessment. Now, when it comes to your primary assessment, you will then assess the baby's airway. You will check to see whether their airway is patent. All right. You will assess whether it is maintainable. So it may be patent. There are no additional sounds that you appreciate. All right. But the baby's level of consciousness means that it is not maintainable. So you need to then use an airway adjunct. At breathing, we want to, so at airway, we have said you assess patency or you ensure patency by doing a head tilt, chin lift, and positioning, if it's an infant, in the neutral position. Remember, they have a larger occiput relative to the rest of the body. So if you place them on a firm, flat surface, there will be some flexion of the neck, which will then cause kinking of the airway. So positioning is something that you can do. Once you have positioned, you then assess whether there's a need for suctioning, and you do your suctioning. Additionally, we check whether that airway is safe. So possibly we insert an airway adjunct. We can start with our basic ones. So we can start with the oropharyngeal airway or the nasopharyngeal airway. Now the OPA, you can only use it if this child or infant is unresponsive and does not have an intact gag reflex. The NPA can be used in a conscious, semi-conscious, or unconscious patient with or without a gag reflex. So if you have an NPA, it's preferable to use the NPA, particularly if you are unsure whether or not the child or infant has an intact gag reflex. Once you have a patent airway, you then move to your breathing. Okay? At breathing, you want to check what is the respiratory rate of my patient. Now, one of the key difficulties here is knowing the appropriate rate for age. Okay? Knowing the appropriate rate for age. All right. So that is something that if you deal with pediatric patients, you must have either you have a chart somewhere where you can refer, or you internalize these figures. So if we are talking about, say, a 2-year-old, what is their typical respiratory rate? About 25 to 37. Okay. In any case, any patient who is breathing at a rate above 65, that is abnormal. That is actually impending respiratory failure. Any patient breathing at a rate less than 10, that is concerning. But you may have failure at rates higher than 10. So if we are talking about a neonate, for example, you do not expect a neonate to have a resp rate of 18 or 16. That is too low, and they are likely going to have respiratory failure. So rate, check the rhythm of their breathing. Are they breathing regularly, or is it irregular? If it is irregular, it suggests that this pediatric patient possibly has a disordered control of breathing, or they have a central nervous system issue. Check the quality. So assess for any abnormal or added sounds. So assess for abnormal sounds. And the abnormal sounds that we are assessing for are those that are audible and those that you auscultate for. So one of the things we must know is, what does a stridor indicate? What does snoring indicate? What do crackles indicate? What do ronchi indicate? What do, for instance, wheezing? What does wheezing indicate? And all these things. So we must have a good understanding of what these particular abnormal sounds indicate in terms of the type of respiratory issue we are dealing with. So one of the things that we say is a stridor, for example, would indicate upper airway obstruction. And all these other things indicate something. So you need to find out, what am I dealing with? Remember, we are evaluating. And after evaluation, we identify, and then we are able to intervene. So you assess the quality in terms of abnormal sounds, assess the depth of breathing. So is it adequate, or is it shallow breathing, or is it very deep breathing, which would suggest perhaps Kussmaul's breathing, which could suggest acidosis. All right. So the depth of breathing. Additionally, are both sides of the chest rising and falling equally? How is the effort? Now, here is where you will assess for utilization of accessory muscles of breathing. So retractions. Do we have retractions? If we do, are they subcostal? Are they substernal? Are they intercostal? Are they sternal? Are they suprasternal? Are they supraclavicular? Okay, so these retractions all indicate a different level of respiratory distress in terms of severity. So mild and moderate respiratory distress, you'll likely have things like subcostal and intercostal retractions. If you start seeing sternal retractions or supraclavicular retractions, then you know that you are in severe respiratory distress and impending respiratory failure. Additionally, we want to assess possibly the positioning of the patient and the SpO2 of our patient. So as soon as we notice, even at initial assessment, we notice that we have a respiratory issue, there's increased work of breathing, you want to apply oxygen on that patient, high flow. All right. Then you now do your pulse oximetry and you find out, this patient is saturating at 100%. So then you titrate downwards. But at least the patient will not be in hypoxia. From there, you then move to circulation. And this is where, first of all, we do our pulse rate. Okay. Okay, thank you, Edgar. So Edgar is just calling your attention to the possibility of using the Q&A box or chat for questions. Yeah. So at circulation, you want to do the inverted J. So you start at your fingertips. You start by checking, is there pallor? Does this patient have pallor? Or you can check the insides of the hands. Do they have pallor, or the soles of the foot? So do they have pallor? But we are talking about the hands. So check for pallor. So you check the color of your patient. You then check the capillary refill time. So you check you are essentially checking for signs of shock. So you're checking for signs of shock. So you start at the fingertips, color, cap refill time. You then proceed check whether you have a temperature gradient. You then check your peripheral pulses, if present. What is the pulse rate? Okay, so another key issue you'll check for is the pulse rate. If your peripheral pulses are not there, are your central pulses present? If they are, what is the rate? Okay, so you then proceed, check the skin condition. Is it warm and dry, or is it cool and clammy? All right, check the blood pressure of your patient. Check the BPs of your patient. Give me a second. All right. You then check the BP of your patient. Now, when it comes to the blood pressure of your patient, it is very important for us to take up this as a practice, checking the blood pressure of our patients, of our pediatric patients, because it's not something that is practiced, but we need to now embrace it, okay? Because that is what will allow you to identify compensated versus we need to start taking up checking of blood pressure. So we need to push to have different cuff sizes, particularly pediatric cuff sizes, because remember, if you have a very large cuff, it will give you an incorrectly low reading. If you have a very small cuff, it will give you an incorrectly high reading. So you need to have the appropriate cuff for age. Now, when it comes to BP, we are saying anyone, so first off, a neonate, you expect their blood pressure to be greater than systolic BP, that is. So we are looking at the systolic blood pressure, the SBP, to be greater than or equal to at least 60. Anything less than that is hypotension. If we are looking at an infant, we are looking at a systolic of greater than or equal to 70. If we are looking at a 1 to 9-year-old child, their systolic, at least minimum, should be greater than or equal to 70 plus 2 times the age. So you do your assessment of blood pressure. You also check for the ECG of your patient. This is something that we do not typically do, but you need to check the ECG of your patient. All right, so connect them to a cardiac monitor, establish IV access, or in cases where we are in hypotensive shock and the veins have collapsed, you can do IO. So IV or intraosseous access. And one of the tools to enable us to do this is an IO drill. So do we have one? We need to have one. So IV or IO access and collect samples. IV or IO access plus samples. All right. So that is your circulation assessment. Now, when it comes to D or disability, the first thing that we look at is our GCS. So we check the GCS of our patient. So we check the GCS of our patient, and this is where I told you there's modifications in pediatrics. So there's modifications in pediatrics whereby we do, if it's eye opening is similar to the adult. So spontaneous eye opening, or opening to verbal, or opening to pain, or no eye opening. So that is how you would score. Verbal, we said, if we are talking about an infant in particular, are there bubbling? Is there bubbling or cooing as you'd expect in an infant? All right. Are they crying but consolable? So bubbling or cooing is a score of 5. Inconsolable is a score of 4. Inconsolable is a score of 3. Incomprehensible sound, so moaning and groaning, is a 2. And then a 1, no verbal response. All right. Motor, spontaneous limb movements, that is a 6. Withdraws to touch is a 5. Localizes pain is a 4. Okay. Or up when we come to pain, what how do we put it? Let me just pull that. Let me just quickly pull it so that I don't mislead you. Okay. Yes, so I have it here. So we are saying if this patient is making spontaneous limb movements, you score a 6. We are talking about the motor component. If this patient withdraws to touch, you score a 5, as I said. If they have flexion appropriate withdrawal upon induction of pain, we score a 4. If they have abnormal flexion, which is decorticate posturing, we score a 3. If they have extension, abnormal extension on induction of pain, we score a 2. And then, of course, no motor response, we score a 1. All right. Now, apart from the GCS, we can also do the AVPU. We can also do the AVPU score. So the AVPU score is something that we know of, but we do correspond A to a GCS score of 15, V to a GCS score of 13, P to a GCS score of 8, and U to a GCS score of 6 when it comes to pediatrics. Very important, RBS. So take the RBS of your patient. If we are talking about a neonate, then typically you expect an RBS score of not less than 2.5, or is it 2.2? Thereabouts. Let me see. 40 divided by 40 divided by 30, 40 divided by 18. Sorry, 2.2. So you don't expect an RBS of less than 2.2. Anything below 2.2 in a neonate indicates hypoglycemia. Now, infants and children, we expect an RBS of at least 3.3, thereabouts, 3.3. All right. So do your RBS and then do your pupillary response. Are the pupils equal, round, and reacting to light and accommodation? All right. Expose. Do a head to toe. Do a head to toe exam as you look for any abnormalities, structural or otherwise. Now, from your primary assessment, you are then able to identify, am I dealing, okay, maybe you are not yet able to identify the exact issue you are dealing with. So you need to do a secondary assessment. But you only do a secondary assessment once you've stabilized your ABC. Okay? This entails a physical exam. So you continue on from your exposure, do a head to toe exam, take the vitals of your patient, bearing in mind the expected cutoffs. So we talked about rate. We said, go and have a look at the expected rates for age if you deal a lot with pediatrics. All right. So go and have a look at the expected blood pressures for age. Go and have a look at the expected pulse rates for age. All right. So many things that you have to identify and align based on the age of that patient. So vitals of your patient. And then, of course, a sample history. So when we talk about sample history, we are saying check your signs and symptoms. Check for any allergies. So ask about medications. Ask about the past medical and surgical history. Ask about last meal, and then, of course, events. So that is your sample history. Now, once you have done your assessment, you have evaluated, okay? So you've done your initial assessment, you have done your primary assessment, you've done your secondary assessment. Identify, all right? So identify. So cardiac arrest pathways, as we started by saying, the first step is early recognition and prevention. Now, when it comes to pediatric patients, the pathways for cardiac arrest are straightforward. Is it a respiratory issue? Okay, if it is a respiratory issue, what is the severity? Is it distress? Is it failure? Of course, if it's distress, oxygen supplementation should work. If it's failure, oxygen supplementation will not work. you need to consider positive pressure ventilation and assisted ventilation, and you also need to consider advanced airway management. Okay, now if you don't intervene, this patient will go into cardiopulmonary failure and a cardiac arrest. If it's circulatory, it's straightforward. Is it leading to shock? And there are different kinds of shock. So what kind of shock am I dealing with? The most common one you might be dealing with in pediatrics due to vomiting and diarrhea is obviously hypovolemic shock. But you can also get septic shock. You can also get obstructive shock. You can also get distributive. So distributive is where then we have our septic and neurogenic and anaphylactic shock. So you identify what type of shock am I dealing with? And if it's shock, do I have compensated shock or is it hypotensive shock? And you manage accordingly. Of course, the cornerstone of management is fluids, except for cardiogenic shock, which is managed slightly differently. Is it an arrhythmia? So if it's a cardiac arrest, then is it a VFib? Is it a VTAC? This is highly unlikely, but can happen. So is it a VFib? Is it a VTAC? Which are shockable? Is it a PEA or an asystole, which are non-shockable? Okay, is it a bradycardia? Is it a tachycardia that is then leading to cardiogenic shock, which is then precipitating or possibly taking my patient towards a cardiac arrest? Early recognition and then prevent the cardiac arrest. So that is the essence of our assessment, systematic approach to assessment. So initial assessment using your PAT, and then your primary assessment, your ABCDE, and then your secondary assessment, identify and prevent the cardiac arrest from happening. I wish to stop there because of time. So I wish to stop there and invite any questions that we might have. I wish to stop there and invite questions. So if you have a question, please feel free to type it in the chat box. All right. Okay, so Edgar, I don't see any questions. Perhaps if there are questions on your end, you can let me know. So Ian is asking, how does the so we are talking about the CAB, Ian. I believe you're talking about the CAB compared to the ABC. All right. So for Ian, I have seen the question. So essentially, the systematic approach dictates there's something that we haven't touched on. Any patient who you find has decreased level of consciousness, in fact, not just decreased, but any unconscious patient, any unconscious patient, you want to first of all start by checking for PALS. So you start with C, check for PALS. Always check for PALS. If PALS is present, then, so no PALS, you start CPR. That is why we start by checking for PALS. Okay, so start CPR. All right, because if we start ABC, by the time we get to C, we have delayed CPR. So any unresponsive, unconscious patient, whether adult or child, start by checking whether they have a PALS. Now, if PALS is present, PALS present, Then you proceed and do your A, B, C approach. Okay, so unconscious patient, we start with C. All right, so CAB for unconscious patients. But patients who you've already assessed C and there's a PALS, you can progress and do your airway assessment, breathing, and then circulation. This also applies to patients who are conscious. So if a patient is conscious, you know, or they are responsive in one way, you are then aware that pulse is present. So you proceed and assess their airway, breathing, and circulation. So I hope that answers your question, Ian. The next question we have is, what are the causes of obstructive shock in children? They are similar to what can cause obstructive shock in adults. So we are talking about attention, pneumothorax, and a cardiac tamponade. So the tension pneumo and your cardiac tamponade will cause obstructive shock. The next one I think is for Edgar. So Edgar is asking, there's a question on how we can get our CPD points. So Edgar, take it away. Thank you, Florence, for the props. Thank you. So Edgar, karibu, and guide us on CPD points and any other questions that you might have seen that I've not seen. I'm still here.
All right. So thank you. Thank you so much, Eric, for that very nice presentation. Thank you also, everyone, for taking the time to attend. So as is a major question all the time is how can we get these CPD points? We need these CPD points. All right. So for medical officers, we'll share the CPD claim cards. So there's a claim card which we'll share likely, let's say on Monday, likely on Monday. For nursing officers, we'll share a certificate. So certificate which you'll upload in the NCK portal, and then you'll get the points. For clinical officers, unfortunately, you still have to come to the office. So please come to the office with your logbook for stamping. So that's clinical officers. So medical officers, claim cards, nursing officers, certificates, clinical officers. You have to come with your logbooks to the office for stamping. Unfortunately, as we speak, we're still talking to the clinicians board, but wanasumbua, but we are working on it. So in the meantime, the only option is just to come to stamp. That's for clinical officers. So all of this should be shared on Monday. Recording for today's session will be shared tomorrow. For those who joined in a bit late, I just want to mention the other courses that we offer. So BLS, ACLS being the most popular. We also offer clinical ECG interpretation. So if you work with the PEDS population a lot, possibly in ICU, possibly in HDU, or just the wards, it's important that you're able to look at the patient monitor and actually understand the clinical significance of what you are seeing. So if that's you, we highly, highly recommend that you do clinical ECG interpretation training. Pediatric advanced life support. The next one will be next month. This will be from 16th to 17th of May. So currently we are around 70 of us in this group. We hope at least one person will come and train pediatric advanced life support. We hope that you have been inspired that there is a body of knowledge that will help you to actually manage your patient when there's an emergency. Yes, so very, very important to do pediatric advanced life support in case you deal with the peds populations a lot. Super, super important. Basic life support, advanced cardiac life support. Just to mention, as part of the Life is Why campaign, we'll be coming to Kisumu, or I should say coming back. We were there 2 weeks ago. Mombasa will be coming to Mutumu, Nyeri, Murang'a, and Machakos. So in case you do have a friend or a colleague who would want to take part, please share. We hope to see them in person for these basic life support, advanced cardiac life support trainings. So a few comments. Can I still get a certificate of attendance? Yes, you can. Please email us na utapata certificate for attendance. Nice presentation. Thank you very much. That's for Eric. Claim cards. We'll share via WhatsApp. They should be on Monday. Yes, so having said that, tunawakaribisha tena. We say a big thank you for taking part in the Life is Why campaign. The reason why we actually do this CMEs is just to share knowledge on best practice when it comes to emergencies. So we hope you'll take them to heart and actually put them into practice. We hope to see you in the next one. We also hope to see you in pediatric advanced life support training. So with that, I want to bid you farewell. Have a good evening. CPD points will be shared on Monday. Yes, also certificates for nurses. The CPD points will be shared on Monday. Have a great evening, guys. See you in the next one. Thank you very much.